So I really appreciate you all being here to hear my presentation. I know that you all are very busy, so without further ado, let's go ahead and get started. So today's discussion would be about heart failure. Let's look at some of the objectives here. The first one is to describe appropriate nursing and interprofessional care to manage the patient with heart failure. Identify risk factors, describe the pathophysiologic changes related to this condition, discuss drug management appropriate for a patient with heart failure, apply a knowledge of anatomy and physiology to perform an evidence-based assessment for a patient with a cardiovascular problem. And also use clinical judgment to assess laboratory data and signs and symptoms to prioritize nursing care for patients with a cardiovascular problem. Let's take a quick look at the incidence and prevalence of this condition. Heart failure is a major problem in this country. It is the most common reason for hospital stays in those patients who are over the age of 65 years old. And this number, of course, is projected to, or rather, the number of people diagnosed with this condition has increased, as you can see here, 5.7 million to about 6.5 million from 2011 to 2014. And of course, this number is expected to go up by the year of 2030 to about 46%. Take a look at the financial burden of heart failure. This does place a significant economic burden on the healthcare system. As you all know, 20% of our GDP is consumed by healthcare, which is a significant amount. It may be even higher than that now. The complex progressive nature of this condition does result in poor outcomes, and these patients are readmitted to the hospital as a result. At least 25% of patients who are discharged with the primary diagnosis of heart failure are readmitted within 30 days. And of course, the problem with that is that hospitals are penalized financially when this occurs. Which is why we have to give our patients a sound education regarding their disease process and how to manage it more effectively in the community. Now, the total cost of heart failure care exceeds $40 billion annually, but more than half of that cost is spent on hospitalizations. Now, what is heart failure? When the heart is diseased, its ability to pump arterial or oxygenated blood to vital organs and tissues is compromised and receives little to no nutrients. Now, essentially, vital organs such as the brain, kidneys, and peripheral tissues are deprived of all the essential elements, minerals, if you will, nutrients, and oxygen that they need. And without adequate nutrients, these organs are not going to work very well. And of course, disease will set in. Take a look at the concept here, the priority concept for this chapter, which is perfusion. Of course, whether a patient has aortic stenosis, dysrhythmias, hypertension, or CAD, there's still a perfusion problems. And so many of the symptoms are pretty much the same. Now, the exemplar that we are using as far as perfusion is concerned is heart failure, as I mentioned earlier. It is also called pump failure. I've also heard forward failure because, as we know, blood is pumped forward. So it's supposed to be. It is supposed to go in a forward direction. It is the inability of the heart to work effectively as a pump. There are a couple of major types. There is the left-sided heart failure, and there's also right-sided heart failure. As far as circulation of blood through the heart, I think students will benefit from doing a quick review of how blood circulates through the heart. As you can see, these arrows, they're pointing in a more forward direction. But of course, when we begin to talk about heart failure, you will see that these arrows will essentially point in the opposite direction. In other words, this blood is backing up instead, which is not good. Right. Now, whenever we talk about the heart failure rather, let's first talk about some of the functions of the heart. I want you to think about hemodynamic regulations, and there are actually three components to this. That first component being preload, the second one being afterload, and of course, the third one is contractility. So I would like to show you an image to explain each of those. I can bring it up here. All right. All right. So what is preload? Preload is the volume of blood that is returning to the right side of the heart that actually sits in the ventricles before systole. That volume of blood in the ventricles um, is referred to as preload, or that volume. So the heart can only handle a certain amount of volume. When that volume is exceeded because blood is not moving forward, then we have to do something to help out an ailing heart. And one of the things we do is we give a diuretic, which you saw on the previous slide, right? And so that's one of the medications we can use to reduce preload so that the heart is not overwhelmed with a lot of volume. All right. Now, afterload means that it is the resistance our right and left ventricle must overcome in order to eject its contents into the arterial system on the left side, at least, which is mostly what we talk about, but also the same for the right side to the pulmonary circulation. But speaking of the afterload on the left side, there are three elements that actually contributes to that afterload or that resistance. One being the viscosity of blood. The other is the fact that the aortic valve, which has to be pushed open, is located on a high pressure arterial side. So it's a little more it takes more strength from the ventricles to open up this aortic valve. And therefore, that also contributes to afterload. What also contributes to afterload is the diameter of the arteries. When the arteries are constricted, there's an increase in afterload. When arteries are dilated, as you can see here, then the resistance is lower, and so the afterload is lower. What we can manipulate is the diameter of these blood vessels. And so if someone has a blood pressure of, let's say, 200 over 120, then they are looking more like this. They're very constricted. And what we have to do, because what happens is when the afterload is increased, the left ventricle has to work very hard to the point that that high pressure can actually damage the heart muscle. And so in order to decrease that afterload or that resistance, we give a patient a vasodilator, right, because we want this here. And this allows the left ventricle to work less. All right, the workload of the left ventricle is reduced, and this is what we want. So we talked about the preload. We can reduce the preload. We talked about the afterload. That can be also reduced. And then we talk about contractility, and that's just talking about the heart muscle's ability to contract. All right. Sometimes heart muscles are very weak, and if they're weak and they cannot contract appropriately, then the cardiac output is going to be compromised as a result. So if it's too much volume, if it's too much afterload pressure to be overcome, if the contractile force is weak, then what you get from that is a poor cardiac output or low perfusion state. All right, so let's go back to our presentation. No, that's not what I want. I think I had it right the first time. Oh, here it is. All right. So one of the things I wanted to do is provide you with some of the medications, classification, some specific medications, and how we accomplish this. One thing I should have mentioned to you also, as far as preload is concerned, not only, well, I talked about how we can reduce the preload by giving a patient a diuretic, but as far as the vasodilator is concerned, let me show you another image to show you how that actually works. This is a great depiction here of what that looks like. So, in order to reduce the amount of blood that is returning to the right side of the heart, what we want to do is vasodilate over here. All right. Whenever this vasculature is dilated, it takes the heart a longer time to fill that enlarged space. And if it takes it a little long to fill the space, it will also delay the amount of time for the blood to return to the right side of the heart. So basically, we're reducing the preload not by excreting volume, but by delaying the amount of blood return to the right side of the heart. And that gives the heart, a failing heart, a break. So I wanted to explain that one as well. All right. Oh. The other drug is the afterload, and as I said, we use nitrates. We can also use ACE inhibitors as well as Rs because these medications can also reduce the blood pressure, meaning the afterload. As far as contractility, we use a cardiac glycoside, which is digoxin, and that also enhances the contractile force of the myocardium. Right? Here's a great depiction of what preload and afterload, what it is. And so the preload is, of course, pouring blood into the heart. And of course, the afterload is resistance to that blood leaving the heart. And I provided some more descriptions of that here, which is pretty easy to understand. All right. For example, hypervolemia, too much volume, right? Heart failure, of course, too much volume in the heart. Heart doesn't work well with too much volume, neither does it work well with too much resistance that it has to overcome. Just makes it work much harder. Right? Let's talk about some other terms how we describe the volume of blood leaving the heart. One of which is stroke volume, the volume of blood pumped from the left ventricle per beat, which it should be between 60 and 100 mLs. Then there is cardiac output, the amount of blood the heart pumps throughout the circulatory system in a minute. And that value or range is 4 to 8 liters. And also ejection fraction, which is a measurement expressed as a percentage of how much blood leaves the left ventricle when it contracts. And so that number or value should be between 55 to 70%. And of course, if that decreases to about 40%, then this is when patients will begin to experience signs and symptoms of heart failure. Let's take a look at some of the etiology of left heart failure. Some of the typical causes is hypertension, coronary artery disease, and also valve disorders. Each of these conditions, they contribute to a high afterload. Hypertension because the arterial system is very constricted, so that increases the afterload. Coronary artery disease kind of acts the same as hypertension in the sense that it makes the diameter more narrow, and so there's more resistance for the heart to work against. And of course, valve disorders, for example, aortic stenosis, we have a valve that is stenosed, and so it's very difficult to push or eject blood through a small opening. So that increases that pressure on that left ventricle. All right. Heart failure was formerly known as congestive heart failure. We don't typically hear that term much anymore. There's two subtypes of heart failure. One is systolic heart failure, and that is the inability to squeeze. All right. And then, of course, there's diastolic heart failure, or should I say, let me back up, the inability of the heart muscle to squeeze. And diastolic heart failure is the inability of the heart muscle to relax and fill, of course. And one or the other or both, if it's present, will result in a reduction in cardiac output. That is the consequence. All right, as far as signs and symptoms of heart failure, and you don't really even have to memorize these. The thing that, or the reasons why these symptoms are present is because there's a reduction of blood flow to our organs and tissues. So as far as weakness and fatigue is concerned, our muscles are not being perfused very well. All right, so it has to make sense. So if you can comprehend it, then there's less memorization, and it stays with you so much longer. Dizziness, you're not perfusing your brain with dizziness as well as acute confusion. There's also pulmonary congestion, things that volume is backing up into the lungs. There's breathlessness because when the patient, especially when they lie down, that fluid, if it mobilizes from the interstitium back into the vasculature, this blood rushes back to the heart, and of course that which is that preload, and it overwhelms the heart, causing breathlessness. Then you have oliguria, the reduction of blood flow to the kidneys, so the kidneys cannot produce as much urine. We have these different heart sounds here, S3 and S4. S3 as early diastolic filling, and S4, the ventricles are stiff. These are the heart sounds that are noted in heart failure. And then, of course, there is pulmonary edema. When there's too much volume in the vasculature of the lungs, fluids have to go somewhere. That volume has to go somewhere, and it seeps into our lung tissue, causing pulmonary edema, which is a medical emergency that we will talk about a little later in the presentation. As far as management, as far as right side of heart failure is concerned, the etiology is left ventricular failure. When the left side, usually the left side fails, and if that is not managed properly, the right side will eventually fail. This is because when the left side cannot push contents forward, then that creates a lot of pressure that the right ventricle has to try to overcome, and that causes an enlargement of the right ventricle. The left ventricle too will be enlarged because of all that pressure that has to be overcome. But on the right side, of course, which is what we're talking about now, it will increase the size of the right ventricle, and it will, at some point in time, impair that right ventricle. All right. Then there's right ventricular MI. Of course, when the right ventricle is impaired due to decreased blood flow, then of course it doesn't function very well. There's also pulmonary hypertension. When the pulmonary vasculature is very constricted, the right ventricle must work very hard to push its contents through the pulmonary vasculature. The consequence of that is the right ventricular muscle is damaged from being overworked, and also the increased volume and pressure in the venous system will occur, and that results in peripheral edema or venous congestion on the right side, and it affects several organs, of course, which we'll see, I believe, here next. Yes, so some of the clinical manifestations, jugular vein distension because of that venous congestion. There's also ascites or third spacing. This fluid is just trapped, right? The fluid is backing up on the right side or the venous side into the GI system and what have you. And so third spacing or ascites can occur. There's also second spacing or dependent edema. There's also hepatomegaly. The liver becomes enlarged because of more congestion from all that volume on the right side rather. anorexia because the GI system becomes engorged with a lot of fluids. And so it gives these patients a feeling of satiety. Um, there's also increased LFTs because again, the liver is engorged and lots of pressure is placed on the liver. So the LFTs, liver enzymes, will be elevated. Let's take a look at some compensatory mechanisms. We'll only discuss a couple of them because of time. So what are compensatory, excuse me, what are compensatory mechanisms? So when the cardiac output is insufficient to meet the body's demands, these are some of the mechanisms that are at play or operate in order to increase the cardiac output. And I'm going to tell you right off, what is happening here is you're either going to have an increased heart rate or an increased blood pressure in order to improve the cardiac output. The problem with this is that if a heart is already ailing and not doing well, you don't want an increased heart rate. You don't want a high blood pressure because that just places, or more volume, because it places more pressure on the heart. And so there are certain medications we use to counteract these compensatory mechanisms. One of those is sympathetic stimulation. When there's a reduction of blood flow to the rest of the body, sympathetic nervous system stimulation occurs. In other words, catecholamines are released. And what these hormones do is it increases the heart rate, increases the blood pressure in order to improve cardiac output and perfusion. Again, a sick heart cannot handle increased heart rate and blood pressure. So we may have to give these patients a beta blocker to block the receptors on the heart, which would decrease the heart rate, block the receptors on the smooth muscle portion of the arteries, and that will vasodilate and cause the blood pressure to decrease, which is what we want. That's better for the heart. The other one is the RAS system. Of course, when renin converts to angiotensin and angiotensin 1 converts to angiotensin 2, you get vasoconstriction, meaning an increase in blood pressure. And then also when aldosterone, the salt hormone, stimulates the receptors on our kidneys, it causes the kidneys to hold on to sodium and then water follows. So now we have this increase in volume, this intravascular volume, which also increases the blood pressure. All right, so vasoconstriction and an increase in volume, which increases the blood pressure, is not what we want for a heart failure patient. And so with these patients, the drugs that we might give them is an ACE inhibitor. That'll stop the conversion of angiotensin 1 to angiotensin 2. So that causes vasodilation. And then the ARB, which is an aldosterone receptor blocker, they are aldosterone receptor blockers on the heart, on the kidneys. And so if we block those receptors, then the aldosterone hormone would not be able to occupy those receptors or stimulate them, which therefore will cause sodium and water excretion, all right, which will lower the blood pressure, and which is what we want in this condition. And this just talks about some of the effects of catecholamines, which I've already discussed. All right, increases heart rate, blood pressure, and also glucose levels. All right, let's take a look at some of the diagnostic and imaging studies. We'll talk about some of the labs. Remember, certain treatments that we administer it means that we should be monitoring the patient's electrolytes. For example, Lasix can deplete our bodies of potassium, magnesium, calcium, and what have you. So we need to monitor the electrolytes for that reason. ARBs can cause hyperkalemia because you're excreting sodium, but then you're holding on to potassium. And so monitoring the electrolytes would be paramount. And then, of course, there's the hemoglobin and hematocrit. There can be a dilutional issue or concentration issue, depending on whether a patient is third spacing, second spacing, or not. If they're holding on to volume is still in the first space, you get more of a dilution effect. If it's concentration, it's because of the fact that some of the liquid part of our blood is moving into those second and third spaces, leaving us a little dry. And so the hemoglobin hematocrit will appear to be much more higher. The BNP, this is a hormone, brain natriuretic peptide. It is a hormone that is produced when the ventricles are distended due to an increase in volume. It produces this hormone. And it is this hormone that actually causes the kidneys to excrete more volume. And so it's kind of like a diuretic in a way of speaking. And so this number actually increases in the context of heart failure when the ventricles are stretched, right? As far as urinalysis is concerned, when the kidneys are not perfused well, the kidneys will concentrate urine, and therefore the urine-specific gravity is going to be higher. As far as APGs are concerned, when there's pulmonary congestion from this forward failure of the heart, then gas exchange is going to be poor as well and reflect that. As far as imaging is concerned, chest x-rays, we can take a look at the heart as well as the lungs and see if there's any congestion that is occurring. Echocardiogram is a great diagnostic tool, one of which it can tell us what the ejection fraction is. It can also tell us if there's a left ventricular hypertrophy, because that happens when the left ventricle has to work very hard to overcome all that afterload pressure and what have you. Then, of course, there's the EKG. This can detect any dysrhythmias that are occurring, which can contribute to this poor perfusion. For example, you'll see that most of these heart failure patients with atrial fibrillation with a rapid ventricular response. And then, of course, there's a tool that we use, an invasive tool called a pulmonary artery catheter or a swan gas catheter. And we can monitor fluids. We can also monitor the vascular resistance within the cardiovascular system. And then we can manage it with medications. We can either reduce the fluids or we can reduce the vascular resistance by either giving diuretics or vasodilators. And so this tool just helps to guide that therapy. All right, some of the priority issues. So whenever we look at a patient with heart failure, there are so many different issues issues of concern for these patients. And so what I want you to see are the as far as the hierarchy is concerned, the greater problems that we need to address. So one of which is we want to increase gas exchange. And of course, we do that with medications and what have you, and optimizing our cardiac output. Same thing with improving cardiac output is one of the other priority issues to address. Do that with medications. There's decreasing fatigue. And so with this, of course, we want to just bundle our task and not be in and out of the room, because these patients, they do need to rest as much as possible. There's also preventing pulmonary edema. And of course, if we can optimize our hemodynamics, improve our blood flow, we can reduce pulmonary edema. As far as increasing gas exchange, more specific nursing interventions, we want to assist the patient with ventilation. We want to monitor the respiratory rate every 1 to 4 hours, auscultate breath sounds, of course, every 4 to 8 hours, and all this would depend on what kind of unit you're on. Elevate the patient's head of bed to hypolys. This will help facilitate breathing. And also we want to maintain the O2 saturation of at least 90%, but of course defer to the physicians or for the parameters. Decreasing fatigue, energy management is very important here. Cardiac rehabilitation will also be important here as well. Functional level can be assessed during cardiac rehabilitation, and of course an activity plan can be crafted. Preventing or managing pulmonary edema, take a look at how we manage pulmonary edema. We want to assess for early signs, of course, which can be auscultation of crackles in the bases, shortness of breath at rest, disorientation and confusion are other assessment findings. Hypolys position, of course, I mentioned that we have to give these patients oxygen, supplemental oxygen. We want to give these patients nitroglycerin because this is a vasodilator or an afterload reducer, can help to push that blood through a whole lot easier. There's also rapid-acting diuretics such as Lasix that we want to give to reduce the preload. And then, of course, giving morphine. Morphine also helps to vasodilate, reducing the afterload. It helps with anxiety and also discomfort. And also continued assessment, and of course, refining our interventions or what we're doing based on the assessment. As far as afterload reducers, we've talked about quite a bit of this already. So just take a look at some of my notes regarding afterload reducers, such as ACE inhibitors, also ARBs. All right. We want to reduce the preload that I talked about. Nutritional therapies such as low sodium, fluid restriction will also be important. As far as drug therapy is concerned, diuretics, we talked about that with decreasing the preload. Venous vasodilators, I talked about that delay of return of blood back to the right side of the heart. There's also morphine sulfate, and we know that causes vasodilation or reduces, or rather, it vasodilates to also delay the return of blood to the right side of the heart. As far as contractility, in order to enhance contractility, we want to use inotropic drugs. These drugs help to improve the contractile force of the heart muscle. We use digoxin here. We talked about that. There's also beta adrenergic blockers that we use in this case because this drug helps to improve contractility and also dilates blood vessels or that afterload. And so it just makes it easier to eject blood from the ventricles. And folks, that is about it.